Welcome everyone to our first webinar in a three-part series on fall risk screening and assessment. The focus of today's webinar is screening for falls in older adults. And today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman, and I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. And Parachute now sponsors the Fall Prevention Communities of Practice, Loop and Loop Junior, along with the annual Fall Prevention Month campaign. Before we begin, we'd like to start today's presentation with a land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous peoples, Canada's First Nations, Inuit and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I'd like to ask that everyone just takes a moment to themselves to acknowledge that the land that they are currently residing and taking this meeting from. Next, I'm going to cover a few housekeeping items during the webinar. If you have questions about the technology, the sound, the video, please type them into the chat box, and my colleague Marguerite will be monitoring this. If you do have questions specifically about the presentation, about the webinar or presenters, please submit them through the Q&A box, and you'll see that option at the bottom of your screen. They'll be answered at the end of the webinar. You're only going to be able to see questions you have asked and not posed by other participants. Right, this webinar is being recorded and it's going to be available at a YouTube link, and that will be sent to all participants in about 1 week along with the presentation slides. You can view other Loop webinar recordings by simply heading over to the webinar page on Loop and clicking on archived webinars or visiting our YouTube channel. All right. So I want to now introduce our presenters, Brian Hyndman, professor at the Michener Institute of Education at University Health Network, Denise Beaton from the British Columbia Ministry of Health at their Injury Research and Prevention Unit, and Dr. Richard Louie, Injury Prevention Specialist at Trauma NB. For a complete bio on our presenters, please take a look at the Zoom webinar invitation or check out the Loop event calendar. So without further ado, Brian, you can take it away and I'll let you share your screen.
Okay. Thank you, Michelle, and good afternoon, everyone. So I'm going to be providing a brief overview on the use of fall risk screening tools among Ontario practitioners. And the information I'm sharing with you is drawn primarily from an environmental scan, as well as a survey of practitioners that I conducted on behalf of the Ontario Fall Prevention Collaborative. I'm going to be speaking in more detail to the latter today, the practitioner survey. I'll have more specific information to share with you about the environmental scan at the upcoming March webinar. So I just want to make sure before I start sharing the survey results that everyone's on the same page about what I mean by fall risk screening versus fall risk assessment, because sometimes those terms do get used interchangeably. For the purposes of this presentation, screening refers to specific tools or measures that identify individuals at risk of falling and determine the need for further evaluation. So things like the timed up and go test or the Berg balance scale, those are examples of fall risk screening tools. Fall risk assessment instruments are longer, more comprehensive and complex, and they refer to algorithms or protocols that not only screen someone's risk for a fall, but provide a more comprehensive inventory of fall-related risk factors like medication use or fall risk conditions that could be subsequently targeted for intervention. And those definitions are based on the fall guidelines that were developed by the Registered Nurses Association of Ontario a few years back. So in the fall of 2020, the Ontario Fall Prevention Collaborative identified the need to basically find out more about what was going on with respect to fall risk screening in the province. So in order to do that, they developed a survey with the purposes of identifying who was using which fall risk screening tools in Ontario. They also wanted to get a better handle on the gaps and barriers that were associated with the use of fall risk screening tools. And lastly, they wanted to understand the implementation and information needs of practitioners and clinicians who were utilizing fall risk screening tools. So that information was collected through an online survey that was mounted on a Question Pro site that was then hosted by the Ontario Neurotrauma Foundation. The survey was in the field and open for completion from November to December 2020. You may recall that wasn't the most optimal time to encourage online survey completion because we were just entering wave 2 of the pandemic. So people were occupied in their day-to-day jobs dealing with the pandemic. So I do believe that impaired our response rate somewhat. In terms of who got the survey, it was sent to all of the collaborative members who were then asked to distribute it to colleagues who they knew who were working in the field conducting fall risk screening in community settings, in acute care settings, long-term care settings, etc. And a link to the survey was also posted on the Loop website to enable Loop members involved with fall risk screening to complete it. It was viewed by 517 people. 70 people completed some portion of the survey and 40 people completed the entire survey. So, I mean, the low response rate gives it limited validity in terms of making conclusions about the broader population of people involved in fall risk screening in the province, but it does still provide some helpful, insightful snapshot information about who's doing what with regard to fall risk screening.
Brian,
These
sorry,
were the, yes.
I just want to interrupt quickly. I apologize. Some of our attendees are just wondering if you could switch to the slideshow view so that the slides are a bit bigger. So at the bottom of your screen, just to the left of the, if you switch to that view.
Is that better?
We are still, oh, maybe my screen is frozen. I'm still seeing the editing view. Oh,
is it bigger now? Because it's showing up as being on the full screen now on my screen.
I'm now seeing a black screen. So maybe, if you return to where you what you were showing, that may just work for today.
Yeah, my apologies about the
No
technology.
worries.
Okay. I can subsequently send you well, you have a copy of the slide deck that people can then refer to get full screen captures. Okay, sorry about the size. So in terms of who completed the survey, we asked respondents to self-identify by sector. And as you can see in this slide, there were fairly close in terms of numbers of respondents between the public health sector, the home and community care sector, primary care, emergency paramedic sector, and broad category called other sectors, and much fewer numbers of respondents in the paramedic urgent care sector. We did want to know what people were doing around screening in terms of using validated tools versus other methods. As you can see from this slide, there was a plurality of respondents who reported using validated tools, and then 40% using observation methods and 50% using in-house tools. And I'll explain a little bit more about what the in-house tools were later in this presentation. Among the 43% who reported using validated fall risk screening tools, these are the most commonly used reported tools, which I'm sure many people are familiar with. The timed up and go test, Morse fall scale, Berg balanced assessment, the simple chair stand tool, staying independent checklist, and you can see the list of other tools. There was a small majority of respondents, 54%, who reported using multiple complementary screening tools. For example, using the tug tool in combination with the chair stand and the Berg balanced assessment. So in terms of people who reported using observational methods, there were a number of observational methods that were utilized in lieu of a standardized fall risk screening tool. That included observing patients' gait and balance, observing their appearance, looking for signs of visible frailty or visible balance deficits, whether or not the patient or client showed up using gait aids or mobility tools like canes or walkers, asking about or doing some inventory on history of falls, and a number of other observational methods, including looking at posture, looking at movement quality, presence of medical equipment, just observing people's ease of movement, cognition issues, donning and removing footwear, etc. The collaborative, as I mentioned, did want to get a better idea about what was keeping people from doing optimal fall risk screening. Number of barriers identified. This table sorts them into the key categories. So some of the key barriers that were identified, barriers to screening that were identified by survey respondents, the fact that the use of some fall risk screening tools required training, which they didn't have the time or resources to implement, lack of organizational support, takes too long to complete, lack of capacity for electronic record maintenance and tracking. Obviously, the pandemic was posing a barrier to doing regular systematic fall risk screening in many settings. Also, lack of knowledge and skills. Again, the issue of requiring too much staff time. The next one I would say is also a consequence of the pandemic, the fact that their fall risk screening protocol could not easily be implemented virtually, and also special equipment and space requirements that they did not have. We also asked respondents to rate the effectiveness of their current approach to fall risk screening. As you can see by this pie graph, about 2/3, just slightly under 2/3 of respondents felt that their approach to screening was fairly effective, and then smaller numbers ranging between perceived marginally effective, very effective, and not effective at all. So how does that correlate to what we know about fall risk screening effectiveness in the literature? And I'll get into more detail about this at the March webinar. One of the major problems that's been identified in studies of fall risk screening tools is that some of the standardized tools, including the timed up and go test, don't have good predictive validity. That means that they don't always do a good job at actually discriminating between those who are and are not at risk of falls and those who do and do not subsequently suffer a fall. There's some research indicating that 3 key measures need to be included in any screening tool. Those are asking the person about their fall risk history, asking about balance and gait difficulties, and actually observing in some way their balance and gait. Those appear to be the key critical indicators of fall risk across all settings, from community settings through to acute and long-term care settings. There is a need for more research on when to conduct screening, what the optimal timing and frequency of fall risk screening is. Do you do fall risk screening upon admission and initial contact with a person, as is often done? Or do you initiate fall risk screening when an individual suffers significant changes in their health status, or even when an older person moves to a new living environment, because that in itself can be a risk factor for a fall if they're in a new living environment that they're not as familiar with. And lastly, needing to strike a balance between what is actually possible in terms of fall risk screening. A lot of literature identifying organizational barriers to doing rigorous screening, not dissimilar to the barriers that practitioners in Ontario identified. So it's really the art of the possible in terms of optimal fall risk screening, ensuring that you have valid screening tools that have good predictive ability, but also being mindful of the actual amount of time and resources that practitioners have readily available in their organizations to conduct screening. So that's it for my presentation, and I look forward to answering any questions that you may have. Thank you.
Thank you, Brian. And Denise, I'll let you start your part of the presentation.
Okay, great. All right. So let me just share my screen here. And there we go. Okay, so I really like where Brian left it there, discussing the art of the possible in terms of fall risk screening. And today, my background's in gerontology and public health, so I'll be taking that lens when I talk about what we're doing in British Columbia, specifically the circumstances that led to the development of a clinical practice guideline for fall risk screening and management among community dwelling older adults, and then our recommendations from the guideline around screening and why we made those recommendations. So I wanted to center this presentation by giving context of who a typical older adult living in British Columbia is. And these are the statistics that are normally presented by our seniors advocate in BC, that a typical older adult in BC lives independently in the community. So they're not in a facility such as long-term care. They have a driver's license and use a personal vehicle as their primary mode of transportation. They have a regular physician. They live without a dementia diagnosis, without a highly complex chronic condition, or receiving home care. And the purpose of this is just to show that while aging has its challenges, older adulthood is not homogeneous, and as I'm sure everybody here knows, spans over 30 years. And so lumping all older adults together glosses over the significant differences. And when we look at the research around how older adults want to age and what's important to them, most older adults do have at least one chronic condition that they manage, and increasing age does correspond with increasing frailty, though, as mentioned, with significant variability. But many of the medical conditions experienced by older adults are more about how they live with the conditions, with the highest quality of life possible rather than about a cure. And in some instances, particularly in terms of frailty, these conditions are linked to the realities of an aging body. And people living and managing daily with complex chronic medical conditions or experiencing frailty are increasingly dependent on others to maintain their health and well-being and want more than medical care. They want to age with as much freedom as possible, to retain as much function as possible, to continue to engage in their community with continued autonomy to shape their own life and story and be able to take part in meaningful activities, maintain social and family connections, and enjoy the here and now and the everyday pleasures of living. And normally I start by discussing this to sort of counter the somewhat ageist attitudes around, well, why bother with fall prevention anyway? Isn't old age characterized by frailty and infirmity? But of course, we know that's not necessarily the case. And falls are a significant threat to the way in which older adults wish to age. I know that many of you are familiar with these statistics or similar ones from your own jurisdictions, so I won't belabor this slide, but I wanted to include it if you want to look at it in more detail when the PowerPoint presentation is shared afterwards. And you'll notice throughout my slides that I have hyperlinked to all of the sources. So why develop a BC clinical practice guideline? When we think of the risk of falling increasing with age, it's not an inevitable part of aging. And the goal of this clinical practice guideline is to bring that conversation into clinical practice that falls are predictable and preventable. And the goal is to prevent falls that result in serious injury and death. Research reports that most older adults under-recognize their fall risk and under-report falls, and that they have a low awareness that falls are preventable and not necessarily a normal part of aging. I want to clarify, though, that this isn't unique to older adults. Everybody under-recognizes their injury risk. So, for example, we know that there's a huge burden of injury from road traffic, collisions, and crashes, but most adults rank themselves as above average drivers. And of course, that's not mathematically possible. The majority can't be above average. But we do have a blind spot in regards to injury. And with falls, clinical assessment by a healthcare professional and multifactorial interventions to address predisposing factors can decrease falls risk by approximately 25% among those at high risk. So how do we delineate among the general population who is at high risk? And that's where screening and interventions come in. So I'm often asked when I engage in these national conversations how British Columbia came to develop a provincial guideline. And I want to be transparent that it is due to a series of formative work as well as ongoing continued efforts. So here's a strategic context timeline just to provide a background. So in 2013, the BC Ministry of Health released the Guiding Framework for Public Health, which lists injury prevention as one of its 7 key goals with a focus on falls. In 2015, the Ministry of Health expanded the mandate for injury prevention at the BC Centre for Disease Control, where it became part of the detailed operational plan. This led to increased funding and the creation of Finding Balance BC. Like other Finding Balance websites, it contains fall prevention information for older adults and their caregivers, as well as healthcare professionals. And it's the center of the annual Seniors Fall Prevention Awareness Week and Month each November. Then in 2017, the BC Injury Prevention Committee underwent a prioritization process to land on 3 provincial injury prevention priorities. And so the BC Injury Prevention Committee has membership from all 5 regional health authorities, the Provincial Health Services Authority, the Ministry of Health, and the First Nations Health Authority. And the purpose of this prioritization process was to really focus their work. And the number 1 priority that they landed on was preventing falls among community-dwelling older adults, with the recognition that the majority of population and public health work around fall prevention that was happening in BC was in facilities because it was driven by accreditation, but there wasn't very much going on, particularly in a centralized, standardized provincial way for the population that lives in the community. And so that led to that prioritization. And then in 2018, the BC Injury Prevention Committee developed an action plan to address falls among community-dwelling older adults, as well as a business case advocating for resources for fall prevention and the other injury prevention priorities. While this business case was well received, it's not been formally approved, but it did raise the profile of injuries as preventable public health problems with evidence-based solutions. And then in 2019, the BC Injury Prevention Committee and the Ministry of Health began work on the BC specific clinical practice guidelines, as mentioned. At the same time, the BC Injury Prevention Committee developed policy relevant performance indicators for injury prevention. And in 2020, the Ministry of Health developed their injury prevention strategic policy framework, and work is ongoing on all of these initiatives. Some of these are currently internal, but the ones that are available publicly are hyperlinked there. And if you have any other questions about the other ones, please reach out to me after the presentation. So the work to develop the guideline truly began in 2018 when members of the working group from the BC Injury Prevention Committee pitched the Guideline and Protocol Advisory Committee, who develop all of the provincial guidelines with representatives from Doctors of BC and the Ministry of Health and Public Health to collaborate to write this guideline. It was extremely well received. And I think oftentimes I get a bit of tunnel vision working in injury prevention in that I don't realize how little people recognize the preventability of things like falls and other injuries, right? Or what a huge burden it is. And the GPAC committee, until this presentation, it wasn't necessarily on their radar in the same way, but it was very encouraging to see that there was so much buy-in. And so over the 7 sessions, we developed the guideline and it was approved for external review in March 2020. Of course, because of the pandemic, it was a little delayed in going out, but it was reviewed in the summer of 2020. So it was reviewed by around 100 physicians, geriatricians, nurse practitioners, and then the public-facing resources reviewed by about 50 older adults. And then this past September 2021, the guideline, the final version was released on the BC Guidelines website. And so the structure of these Made in BC guidelines are set by preceding guidelines, and we followed this format to ensure ease of access, going through the scope all the way to the appendices. And the focus of the guideline is community-based primary care, although it may be useful in other care contexts. Hospital and facility-based care settings were outside the scope of this guideline as we developed it. And so the risk factors associated with falls and fall-related injuries can be categorized into 4 dimensions: biological, behavioral, environmental, and socioeconomic. And this is one of the tables of risk factors, the major risk factors. So we know that 1 in 3 people over age 65 fall every year, and yet less than half of them tell their doctor about it. The development of this guideline drew from the research literature, the American Geriatric Society and British Geriatric Society guideline, the RNAO guideline, and then also the CDC guideline out of the States. And they recommend screening for fall risk annually. And we were really searching to see, okay, why annually? And it seems like that's just the way that it fits best into clinical practice. So we adopted that because we wanted clinicians to know that screening is a simple process that can be implemented into practice with tools that fit the normal workflow. And for patients with multiple health concerns, so for example, from the risk factor table, we recommend rolling assessments over multiple visits, targeting at least one area of concern at each visit. And we'll get much more into the assessment at our next webinar in March. So here's for the screening. So we recommend at the screening level, 1 of 2 evaluation tools to assess patient fall risk. The first is that the primary care practitioner asks 3 questions as needed. So have you fallen in the past year? If so, how many times? And were you injured? Do you ever feel unsteady when you stand or walk? Do you worry about falling? And if the patient answers yes to any of these 3 questions, the recommendation is to then carry out a multifactorial risk assessment and fall history and do referrals to community resources. The second way for screening is that the patient completes the Staying Independent questionnaire, which was chosen because it's already in use in BC. It's a familiar and effective screening tool, and it's practical. It can be done in the waiting room. It can be made available at community centers or libraries. And then the older adult can bring it to their GP appointment if, they have 4 or more yes responses, and are evaluated through the questionnaire as at risk. I also want to acknowledge that we have this dichotomy of evaluated as not at risk and evaluated as at risk. This is just for simplicity's sake. What evaluated not at risk means is that the patient's fall risk is not significant enough to impact their clinical care that year. The recommendation is that this brief screening takes place each year or any time the patient presents with a fall or a significant change in health status. So for those who are evaluated as not at risk, there's still an opportunity to discuss how to manage falls risk to continue to maintain that lower level of falls risk. And it's really about starting the conversation and seeing that this is something that should be discussed in clinical care and that falls risk can be managed. So at our next presentation in March, I'll go over the recommended steps for the multifactorial risk assessment and fall history. And then at the following presentation, which I believe is in May, I'll discuss the implementation and evaluation of this guideline. But for those of you who would like to review the guideline and its resources in its entirety before then, here's the hyperlink. But I'm really looking forward to these upcoming presentations as well, because of course then we get into how do we tailor these recommendations and really ensure that this is implemented into practice and that it meets the needs of diverse groups and populations of older adults, including indigenous populations and various language populations, etc. But that's all to come. So finally, I'd like to acknowledge that the work and efforts of my colleagues who developed the proposal for the guideline, as well as the guideline development working group. So thanks very much.
Thank you, Denise. That's great. And yeah, now we'll turn it over to the final segment of the presentation before questions, which is Richard Louis.
All right, everyone. Hopefully everyone can see my presentation. So with that, today, I'm mainly going to speak about, our efforts here in New Brunswick that we've made over the past few years in order to implement and support efforts to have enhanced fall risk screening here in this province. And this has been collaborative efforts with many provincial stakeholders. However, it all starts with getting a better understanding about what's happening on the ground. So we all know that for many, many years, governments and members of the public have recognized the importance of taking steps to address communicable disease. I mean, I don't need to mention the pandemic, but as you can imagine, the same type of reflection has been made more recently in order to recognize the importance of taking measures to address chronic disease. And even more recently, the importance of taking steps to address intentional injuries by bolstering or making more readily available mental health services. However, when it comes time to think about unintentional injury prevention, that reflection oftentimes is more difficult to happen. And unfortunately, for too many people, falls, for example, are seen as a normal part of aging. It just happens, whether it's getting governmental decision makers to understand the importance of allocating necessary resources, or just getting members of the public, older adults, to recognize the importance of their role in helping to prevent injuries and preventing falls. So here is just to illustrate one study that was made back in 2012, looking at the relationship between older adults and their primary care providers. And here specifically looking at how comfortable individuals were to admit that they've had a fall in the past 12 months. Here, just looking at females, we're looking at about 31% that admitted to their primary care provider that they have had a falls. So like that would in turn, hopefully initiate the screening process. However, when we're looking at males, older men, we're looking at 24% feeling comfortable admitting that they've had a fall. So this is the reality on the ground that we're more or less faced with. And when we're talking about decision makers or government representatives, for them to understand that similar language that we're using with this current pandemic, trying to flatten the curve, is something that needs to be understood fairly well, even though the speed at which cases are going to be faced with are not coming as quickly as the different waves with this current pandemic. But we can still see with an aging population here in New Brunswick that the number of cases going from 2010 to 2020 to 2030 to 2040 is going to make a considerable impact on our healthcare system. So knowing fully well that we're not going to have double the number of hospital beds for those fall cases, what can we do to reduce the demand on our healthcare system? So here, what we've done here in Trauma New Brunswick was to, number one, look at available resources in order to support fall risk screening and assessment and interventions. And the first step that I took really was to complete a revision to a previous fall risk screening, assessment, and intervention algorithm that I developed back in 2016. So this revised version really simplified the content and really provide individualized interventions for older adults, both at low risk and at high risk for falls. Beyond that, we also developed some additional accompanying resources for healthcare professionals so that they can further be helped with the screening process at least. So with that, we now have a clinical practice guideline. We know what steps should be taken. However, how do we implement this so that it actually happens on the ground? So looking at best practices, here's a really interesting study that was led in the States, this is a study led by the Milwaukee County Falls Prevention Coalition, looking at efforts to coordinate fall prevention efforts between emergency departments and community services in that county. Early enough, that coalition recognized the need to focus on creating access to fall risk screening programs. So whether it was completed within a primary care provider's office or within a fall prevention clinic, the idea here is to provide more capacity in order for fall risk screenings to be at least completed annually for all older adults. Beyond that, they've also recognized the importance of leveraging existing resources, specifically those developed by the CDC for the STEADY program, in order to raise awareness about the importance of fall risk screening. So similarly, here in New Brunswick, we've spend some time in order to develop a strategic plan outlining what would be the next steps with regards to implementing best practices for fall risk screening, intervention, and screening, assessment, and interventions. So for fall risk screening, similarly to what Denise just mentioned earlier, we are advocating for the use of the same 3 questions or the staying independent checklist. Now, whether the patient is able to respond to the staying independent checklist and providing a score of 3 or less, or the patient answered no to all the key questions, they would be in turn referred for interventions for patients at low risk. However, if there's any answered questions in the affirmative, or if they obtain a score of 4 or more on the staying independent checklist, that's where you proceed with the second phase of the screening process, which would be a mobility assessment. Now, just like the study that I mentioned earlier, they've been using CDC's resources. Here in New Brunswick, we've been doing the same thing, however, making sure that all resources are available in both official languages in order to be sure that we're able to target both Francophone and Anglophone communities here in New Brunswick. So for that, we have our version of the staying independent checklist, which also includes the same validated questions that we recommend older adults to fill in. So since it's a self-screening checklist. So beyond that, we also worked on providing support for mobility assessments, whether it's through the time up and go, the 4-stage balance test, or the 30-second chair stand test. So really, the reason why we're advocating for these 3 tests is because they can be completed with limited time and limited available space, so that primary care providers within their clinical practice could complete these simple tests. Now, if no mobility issues have been identified, like I mentioned earlier, you can refer that person for interventions for an individual at low risk if they haven't had a reported fall in the past year. Or reported issues. But beyond that, if a patient demonstrates any reports of difficulties with their mobility, that's where you conduct a multifactorial fall risk assessment. So really, it's to conduct that mobility assessment, and depending on the results, that will definitely lead you to understand the need to either provide those individual interventions for someone at low risk, or to continue with the multifactorial fall risk assessment. And one thing to really keep in mind is that multifactorial fall risk assessment is not considered necessary for our older adults. Reporting a single fall in the past year without any reported or demonstrated mobility issues. So really, this has been determined from the latest clinical practice guidelines from the American and British Geriatric Societies. So really, this is to keep in mind when we're advocating for steps that we need to take when we're talking about screening, and those that we don't need to take. So just like with the fall risk screening checklist, we've also developed some additional resources in order to help with the mobility assessment components for healthcare professionals who might need that extra support. So both for the time up and go 4-stage balance test and 30-second stair test, they can simply use this simple pamphlet to be reminded of the purpose, the directions that should be given to patients, and the observations and the interpretations of the results of the different tests. So with that, we also developed a fall risk factor checklist, a simple 1-pager that primary care providers could use in order to really check off the steps that were taken in order to be sure that nothing's being left over with regards to the initial screening and the gait strength and balance evaluation. And like I mentioned earlier, the interpretations of those results are even placed at the bottom of that 1-pager, with the reverse side being reserved for the multifactorial fall risk assessment, which we will talk about at our second part of this webinar series. So just to mention, obviously making all of these resources readily available online on findingbalancenb.ca, or Finding Balance New Brunswick website. So resources are available for older adults, elders, professionals. So really to make those resources readily available online through that online platform was something that we felt was really needed. However, in order to reach out to older adults who might not be as computer savvy or not might not go on online as often, we've also focused on a public awareness campaign during Fall Prevention Month specifically, where we're encouraging older adults to have that conversation with their family, their friends, with their local pharmacist or primary care provider about their risk of fall, so that they can in turn have a better understanding about the importance of doing a fall risk screening. So beyond that, what we've done this year, or should I say for Fall Prevention Month, November 2021, was our collaboration with the New Brunswick Pharmacists Association. So like I mentioned, older adults might not feel very comfortable going online by themselves. However, during their visit to their local pharmacist, they would be encouraged, their local pharmacist would be encouraged to have that conversation with their older clients about the importance of continuing the conversation about fall risk screening with their primary care provider, but also to set up a date and time for a medication review at a later date in order to assess their risk of adverse reaction because of taking multiple medications. So with that, we did provide some simple postcards, simple cards that all pharmacies throughout New Brunswick were encouraged to give to older patients in order for them to be encouraged to go and get more information through falltalk.ca. So obviously, like I mentioned earlier, all information is available in both official languages. And in order to be sure that we're reaching out to as many older adults as possible. Beyond that, we've also worked on some radio, TV, newspaper ads about the importance of continuing the conversation around fall risk screening and assessment. The tagline, like you can see, this fall, let's all talk falls, really puts the onus not just on our primary care providers, but on everyone in order to encourage fall risk screenings. So really, that's what we've been focusing on here in New Brunswick over the past few years. However, we're already planning for next year, where we intend to continue our collaborative effort with New Brunswick Pharmacists Association. However, to get even more collaborative buy-in from our primary care providers in order to ensure that annual fall risk screenings are completed for all older New Brunswickers across the province. So much more to come, but obviously we really want to thank all stakeholders who worked with us over the past few years in order to bring us to where we are today. And with that, I really want to ask a question to all of you who are listening to this presentation today is, are you aware if your community, your province, or your territory is considering to implement a similar strategic plan to ensure that all older adults are screened at least once a year? And with that, I'll just let that question marinate, and hopefully you might use that as a good reflective time to maybe reach out to those who might be in the know within your province in order to see what role you could play within the larger collaborative fall prevention team. So again, just want to thank you very much for this opportunity. And with that, I'll bring it back to Michelle Duckman in order to finalize this session.
Awesome. Thank you very much, Richard. I'm going to share my screen, and it will have everyone who presented today their contact information for those who would like it. Like I said, the slides will be shared afterwards, so you'll be able to get these coordinates following presentation too. I just want to say thank you, Brian, Denise, and Richard, for an excellent first webinar in this fall risk screening and assessment webinar series. We did have a couple of questions crop up in the chat and the Q&A box. So we're going to address these momentarily, but first, just a couple of housekeeping items before we move on to our question period. But participants, if you do have any, in the meantime, if you do have any additional questions, please enter them into the Q&A box and we can answer those in a moment. When the webinar does end, you are going to be redirected to Zoom and invited to participate in a short evaluation survey. So you just click the blue continue button on your browser and you'll be redirected to that survey. The last question of the survey, it does ask for additional comments or if you have suggestions for future topics. So those can be for Loop webinars in general, but since this is a series and we want to give you exactly what you're looking for out of this series, please feel free to be specific about the subsequent webinars in this series, specifically our upcoming one in March. That's going to be focusing on assessment. So if you have specific questions that what you would like to be covered, please include that because we'll be looking at that feedback and incorporating it into the next webinar, which is on March the 8th. So save that date in your calendar. Registration information will be made available shortly, but for now, just know that it's going to be on March 8th. So moving on, we can go to the questions. I'm just going to pull them up on my screen so that I can walk us through. Alrighty, so I think the first question, it looks like was for Brian. Brian, are you able to speak to which professionals took part in the survey? I know you touched on that a little bit, but maybe just for if that attendee is still on the line to answer that question.
Sure. I don't have the exact numbers handy, but it was a very wide range of professionals, primary care physicians, geriatricians, nurses, nurse practitioners, public health nurses, physiotherapists. The professions here responded to the survey really reflects the diversity of fall risk screening pathways in Ontario, I would say.
Yeah, awesome. Thank you for that. And then the next question, they ask, was SCOT fall risk assessment also used? This is widely used in long-term care. Do you know the answer to this one?
I think the person who typed that question is referring, I think, to the Beach tool by Vicky Scott. I don't recall that tool being mentioned specifically. It is an older tool, so it may not be used in long-term care and other settings to the extent that it was even a few years ago. But yeah, I don't recall that being mentioned by respondents as a fall risk screening tool that they were utilizing.
Alrighty, thank you for that answer.
Also keeping in mind that we had, as I mentioned, a small response rate. So there may be people who are using the tool who didn't respond to our survey.
Yeah, that's a good point. The next question was, what numerical value of future falls risk defines the threshold between low risk and high risk in these screening methods? Example, 30% or 60%. I believe that would have been, Richard, would that have been for your section of the presentation? I'm just looking at the timestamp on the question. If none of our presenters know exactly what that's referring to, we can always follow up with that person potentially.
I mean, I can briefly talk to it. I wish this wasn't an anonymous attendee because it's a great question and I'd love to know who you are.
Right.
So I can say that when we were looking at what screening methods we would include in the guideline, we were really focused on, how do we stratify risk and what is the predictive validity of these tests? You know, how good are they at predicting future falls, not just present fall risk, and how does present fall risk correspond with the likelihood of future falls? So for us, we just went with the dichotomy at risk for falls and not at risk for falls. And as I mentioned, not at risk for falls means that simply they won't be recommended to have the full fall risk screening assessment. In terms of the 3 questions that are asked and the staying independent checklist, they're fairly similar. So the 3 questions are on the staying independent checklist, right? Have you fallen in the last 6 months or a year? You know, do you feel unsteady when you walk? And are you worried about falling? And so the staying independent checklist has been found to have concurrent validity, but predictive validity is a little bit trickier. And so it's really more so looking at the parts of it. So for example, we know that a past fall is the strongest predictor of a future fall, around like 30 or 40%, and that fear of falling also strongly predicts a future fall as well, because around 20 to 40% of people who have fallen develop a fear of falling, and then of course in response to this fear can then restrict their activity, which actually further deconditions them and ironically predisposes them to a fall. So ultimately what we did in including these screening questions is seeing it as a gateway for further assessment, because we couldn't get clear answers around stratifying risk in the way that they've done with many other guidelines, you know, around cancer, et cetera, where there's been decades and decades of work. I hope in the future that we'll have a clear answer to that question, but as it currently stands, we're looking at it as a gateway, and more so being concerned not so much at the rate of falls, but whether or not the risk is there for the next fall to result in a serious injury or death.
Thank you, Denise. I'm just going to note that we will end right at 1, but I know that we do have some other questions in the Q&A. So if we don't get to your question, or those who haven't asked a question, but you just want to know all the answers, just know that we will upload a document with some written answers to the outstanding questions, and that will be posted on Loop. So with the last couple of minutes that we have, I'll continue on, but just know that we will eventually get to your questions if we don't get to them right now. The next question, or maybe it was a comment, but it says medical conditions should include upper extremity arthritis / conditions which can prevent the use of mobility aids and may reduce balance for those who cannot use the arms to counterbalance. So I think a suggestion made from the audience. I don't know if anyone has any comments on that. Ready. The next question, is there any plan to involve people who are not 65 yet, but due to medical condition are at high risk of falls?
Well, I can speak to a new project that we're considering exploring to put in place here in New Brunswick, which would be to try to target men to be physically active with regards to taking steps to improving their mobility. However, in order to target the right individuals, because we don't want to be picking those who already are good with their mobility. So in order to screen for the right participants in those exercise-based fall prevention programs, this is where we're going to try to come up with a strategy in order to get them to want to be screened. So that's going to be part of my challenge for 2022, is to come up with a strategic plan in order to reach out to men who might not feel comfortable going to see their primary care provider or to be engaged with healthcare services. So how can we engage with them wherever they are during their leisure activities in order to in turn encourage them to take steps to, number one, get screened, and in turn, if they're at higher risk, to participate in those exercise-based fall prevention programs.
Thank you, Richard. And we might have time for one last question, and a comment also from Chris Bidmead. Excellent presentations, and so good to see that screening on each coast of Canada are using the same questions. This question could be answered by anyone, but do you think there is any hope that we could move to a national approach in every province?
Honestly, that's my wish. Just to say that in 2021, actually, just recently, we've really made a national effort to get stakeholders from across Canada to have those conversations in order to share resources and to share our experience with our strategic implementation of best practices, so that those conversations aren't just happening between New Brunswick and BC, but to also include the other provinces and territories, so that across Canada, we all follow the same screening process. So again, this is going to take some time, but the good news is those conversations are happening.
Yeah, absolutely. Alrighty, so it's 1:01, so I guess I lied that we were going to stop right at 1, but thank you again to our presenters. Thank you for everyone for attending. Thank you for all the kind words in the chat, and we will see you again on March 8th. And keep an ear out for the webinar recording, unanswered questions, and these slides. So thank you again, and have a wonderful afternoon, everyone.
Thank you. Bye, everyone.